So we'll invite the next speaker up to the podium. This is Elionia Ivanova. Elionia is pursuing a PhD in medical sciences at the University of Toronto under the supervision of Dr. Das. Her research focuses on developing novel therapies to overcome chemoresistance in glioblastoma, the most common and aggressive primary malignant brain tumor in adults. Working in the Brain Tumor Research Center at the Hospital for Sick Children, Elionia collaborates closely with bioinformatics clinicians, neuropathologists, and scientists to bridge the gap between clinical practice and foundational research. Her work aims to advance therapeutic options for glioblastoma patients, bringing hope to those affected by this challenging disease. Elionia also serves on the Executive Committee for Panoramics, a pan-Canadian collaborative working cluster for spatial and single-cell multiomics technologies and projects. She's the Executive Director of the distribution at the IMS magazine and a professional figure skater. Her talk today is Lumitapide enhances cytotoxic effects of temozolomide in chemo-resistant glioblastoma, and the discussant is Dr. Gallie.
Thank you so much for the introduction, and it's my pleasure today to present our very translational project on repurposing the lipid-lowering agent lumitapide for glioblastoma treatment. Globally, over 241,000 people die each year because of the brain or nervous system cancer, with glioblastoma accounting for about 48% of all malignant primary brain tumors. Being the most common and the most aggressive form of malignant CNS tumor, GBM is characterized by a low 5-year survival rate of less than 10%. Median survival of GBM patients is only 14 months. Survival rates and mortality statistics for GBM have been virtually unchanged for decades. In addition to being life-threatening, GBM and its harsh treatments inflict devastation upon the brain, which controls cognition, mood, behavior, and every function of every organ and body part. Many patients lose their ability to work, drive, and a host of other functions that contribute to one's sense of self and independence. And despite first being identified in the scientific literature in 1920s, there have only been 4 drugs and 1 device ever approved for the treatment of glioblastoma. And none of these treatments, unfortunately, have succeeded significantly in extending lives of patients beyond a few extra months. The current standard of care for patients with glioblastoma, the STOP protocol, has not changed since 2005. The first line of treatment for adult GBM patients younger than 70 years of age involves maximum safe surgical resection, concurrent radiotherapy with temozolomide. Plenty of GBM studies have been conducted over the last 2 decades, but only a few of them have led to therapy improvement for patients. Some other trials have been terminated due to unacceptable toxicity. And given the preponderance of unsuccessful trials in recent years, it would be prudent to invest more time and effort in trials involving alkylating agents such as temozolomide, as they're the only agents that have demonstrated systemic therapy benefits over the years, while numerous novel, costly treatments have failed to do so. We also need more agents with lower systemic toxicity, so that we do not only improve patient outcomes, but also decrease side effects associated with chemotherapy, and improve overall quality of life. In order to speed up the drug discovery process, our approach was to repurpose an FDA-approved agent for glioblastoma treatment. While de novo drug discovery and development is a lengthy, costly process involving high risks, drug repurposing is advantageous for its time and monetary efficiency in advancing chemical leads for clinical studies. It significantly decreases time required for the agents to go from bench to bedside, as toxicological data is already publicly available. So in this study, we have performed a high-throughput drug screen using a library of approximately 900 FDA-approved agents capable of crossing the blood-brain barrier. We screened T251 glioma cells and temozolomide-resistant glioblastoma cells in presence of temozolomide, so we can identify the drug that will impact cell viability. We identified a lipid-lowering agent, lumitapide, also known as Juxtapid in the US, as a promising chemosensitizer in GBM. Lamidipine received FDA approval in 2012 for treatment of homozygous familial hypercholesterolemia, which is a rare genetic disorder that causes extremely high levels of cholesterol in the blood. It has established pharmacokinetic, pharmacodynamic, and safety profile from clinical studies. It is also an oral drug that has readily absorption and is capable of crossing the blood-brain barrier. We assessed the drug response in vitro by subjecting U251 glioma cell lines and temozolomide-resistant cells to treatment with lamidipine alone, temozolomide alone, or the combination of the two drugs. And we found that supplementing the standard of care temozolomide with lamidipine presented synergistic drug effects that considerably decreased cell viability in both the control line and especially so in the temozolomide-resistant population. Lamidipine enhances cytotoxic effects of TMZ not only in the immortalized cell lines, but also in patient-derived cell lines, glioma stem cell lines. Supplementing TMZ with lamidipine also results in significant decrease in cell viability. To examine whether lamidipine treatment combined with TMZ affected tumorigenic capacity of glioma stem cells, we also performed non-adherent sphere assay by pretreating the cells with the combination of the drugs. We also found that these cell lines formed smaller spheres compared to those treated with temozolomide or just lamidipine alone. We then investigated whether lamidipine exerts any cytotoxic damage on normal cells. And we found that HEC293 cells used to represent human embryonic kidney as healthy tissue, as well as normal human astrocytes, have minimum reduction in cell viability. What is more, we noticed that when supplemented with lamidipine, TMZ can be used at lower doses while achieving the same cytotoxicity. This has potential to reduce chemotherapy-associated side effects even further. Also, by measuring the reactive oxygen species levels in the cells, we found that cellular ROS burden was significantly elevated in U251 glioma cells, temozolomide-resistant cells, but not in the normal tissues, further emphasizing low cytotoxicity and clinical transferability of this agent. Our in vitro findings support the conclusion that lamidipine enhances glioblastoma sensitivity to TMZ. And to determine whether these findings are relevant to the disease state of glioblastoma, we have also evaluated the effect of lamidipine treatment in combination with TMZ on tumor growth in a glioblastoma xenograft mouse model. Following intracranial inoculation with luciferase-expressing U251 cells, we have allocated the mice in three groups: control, lamidipine-treated, temozolomide-treated, or temozolomide and lamidipine together. And we found that control and lamidipine alone treated mice displayed weekly advances in tumor growth and all succumbed to their disease within 3 weeks post-inoculation. Lamidipine alone demonstrated no efficacy on anti-tumor activity. However, the addition of lamidipine to temozolomide therapy resulted in a more significant period of remission compared to temozolomide alone. So while temozolomide alone treated mice show a reduction in tumor burden at week 2, the tumors returned by 4th week. However, tumor burden in mice receiving combination therapy was significantly lower, and the recurrence was delayed until week 5. Lamidipine also improved survival when combined with temozolomide at clinically relevant doses. The safety profile of lamidipine in humans has been established by clinical studies for homozygous familial hypercholesterolemia, and we observed no systemic toxicity in vivo at doses within those approved by FDA for treatment, highlighting the potential of this agent to be translated to clinical application in treatment of GBM. So I've talked a lot about the efficacy of lamidipine in sensitizing glioma cells to the effects of temozolomide, but we haven't yet touched upon any of the functional studies. Why is it that lamidipine acts so specifically on glioma cells, and how does it enhance cytotoxicity of temozolomide? As a lipid-lowering agent, lamidipine disrupts cholesterol homeostasis. In cancer, glioma cells act like parasites on the brain's cholesterol system, because highly proliferative cells require increased cholesterol levels compared to their healthy counterparts. And to meet these metabolic needs, most cancer cells display an increase in de novo cholesterol synthesis to maintain optimal intracellular cholesterol concentrations. In fact, highly proliferative GBM cells are dependent on cholesterol for survival. Lamitabide belongs to a family of lipid-lowering drugs, or otherwise called statins, and previous studies have shown that statins may act as antineoplastic agents through inhibition of mevalonate pathway, an essential step for de novo cholesterol synthesis. However, no studies have previously reported on lamitabide in this context, but we hypothesize that it may act in a similar manner. One of the metabolites, CoQ10 or ubiquinone, which is downstream of mevalonate pathway, normally protects the cells from oxidative damage. However, in this cell line, in this context with lamitabide treatment, we have noticed an increase and a significant ROS accumulation in these cells, which could be regarded as one of the hallmarks of ferroptosis or cell death. To summarize, de novo drug discovery and development is a lengthy process involving high risks, while drug repurposing is advantageous for its time and monetary efficiency. It significantly decreases the time required for agents to go from bench to bedside as toxicological data is publicly available. In this context, we are proposing to repurpose lamitabide as an adjunct treatment to temozolomide for chemotherapy-resistant glioblastoma. It's an FDA-approved agent with established PK and PD and safety profile. It's capable of crossing the blood-brain barrier, and it's an oral drug. It sensitizes GBM cells to chemotherapy, thereby enhancing cytotoxic effects of temozolomide. It is also effective in reducing viability not only in immortalized cell lines, but in patient-derived cell lines. It has minimum toxicity in normal cells. And once supplemented with lamitabide, TMZ can be used in glioblastoma mouse model with delaying tumor recurrence and improving survival at well-tolerated clinical doses. And with that, I would like to thank my supervisor and everyone who has contributed to this study, and I'll be happy to take any questions.
Thank you very much for an excellent presentation. And before I ask you any questions, I just want to also congratulate you on being a professional figure skater, seeing that I cannot skate at all. So this is an interesting arena, metabolic reprogramming in cancer. And for those of us that do translational research, for example, in sarcoma, and it's not fair to ask you this because it's not published just yet, we found in sarcoma high throughput screens that anti-cholesterol activity is actually similarly important, but not the same mechanism per se. So do you want to tell me a little bit more details about your screen? You screen one cell line or multiple cell lines? Just to understand that what you're triaging out of 900 compounds, given the heterogeneity of cancer, would be applicable to many patients. So one cell line or multiple screens?
In this screen, we screened U251 glioblastoma cell lines, right, as well as the temozolomide-resistant cell line that we have developed in our lab by serially exposing U251 immortalized cell line to treatment with temozolomide.
Okay, and then in your spheroids, which is a nice functional validation, how many of those seem to be responsive to the combination therapy? Were all of them, or was there a variable response seen?
We screened 3 patient-derived spheroid cell lines in total. All of them seem to have a response. However, some are more sensitive to the treatment, while others still respond, but not as well.
Okay, my final question really relates to the metabolic reprogramming usage of drugs like anti-cholesterol agents. The other big drug is metformin. People have tried to use as a repurposed agent to try to stop sort of the fuel of cancer cells. In your mouse models, you could see that there was a nice initial in vivo synergy, but in our work, Neil Fleschner's actually done work the urologists have in breast cancer. People have sort of shown that there is a pretty rapid flux back through the mevalonate pathway where it stops working as effectively. Have you thought about trying to ensure that your duration of therapy is robust. I'm not sure what your thoughts are on that.
I think definitely more testing is required to determine the optimal regimen strategy, as well as what is better, to administer lamivudine prior to conventional chemotherapy, to keep administering it while the patient is on chemotherapy, or do we also administer it as neoadjuvant treatment?
Yeah, our window of opportunity is a really good option for patients too. Thank you.
Absolutely. Thank you.
We have time for one question, Dr. Forbes.
Sure. No, congratulations. There was many fascinating aspects to that talk. I wanted to move back from the in vitro and in vivo tests and look at the upfront identification of the drug. And we've heard a lot that artificial intelligence is going to revolutionize drug development, drug identification, repurposing of drugs. I wonder if you maybe want to expand on that, about how the future of drug development is going to be influenced by AI.
I think definitely it would be a great idea to conduct an in silico drug screen, or maybe AI can help us determine the optimal treatment strategies, or even help stratify patients better based on their response to therapy. So we can benefit from more studies conducted on patient stratification using machine learning or AI.
Thank you very much. Excellent
Thank you.
presentation. Our next speaker will be Dr. Jethro Kwong. Jethro Kwong is a third-year urology resident at the University of Toronto. He recently completed a master's in health system artificial intelligence as part of the surgeon scientist training program. His research focuses on integrating AI into urology, particularly in prostate and bladder cancer, and establishing best practices for AI implementation in medicine. His work has been supported by peer-reviewed grants from CIHR, Canadian Urological Oncology Group, Bladder Cancer Canada, and the Temerity Centre for AI Research and Education in Medicine. His research has been published in some of the top AI journals, including the Lancet Digital Health, NEJM AI, and Nature Digital Medicine. Beyond research, he is also committed to advancing AI literacy in medicine. He serves as a trainee advisor and education theme volunteer for TCARM, and is an editorial board member for Nature Digital Medicine. His talk today will be an artificial intelligence-based model to predict progression risk in non-muscle invasive bladder cancer and improve substratification of intermediate and high-risk patients in international model development and evaluation study. Dr. Kwong.
Thanks so much for the introduction and for the opportunity to present today. So my name is Jethro. I'm a urology resident, and it's a pleasure to share this international collaborative project that we've been working on over the past few years in trying to improve prognostication in non-muscle invasive bladder cancer using AI. And this is done under the supervision of Drs. Girish Kulkarni, Dr. Alexander Zlata, and Dr. Alistair Johnson. No conflicts of interest to disclose. So believe it or not, bladder cancer is actually one of the most expensive cancers to treat on a per patient basis. It has a very, very high recurrence rate, and that often necessitates lifelong surveillance through cystoscopy and oftentimes repeat resections for bladder cancer recurrences. It's also coming up in incidence, so it recently went up from the 10th to now the 9th most common cancer worldwide. Now, we typically classify bladder cancer into either non-muscle invasive or muscle invasive bladder cancer, and that's based on the depth of tumor invasion into the different layers of the bladder. Most patients are diagnosed with non-muscle invasive bladder cancer, and this typically has a pretty good prognosis, but up to 20% of patients will progress into muscle invasive or higher disease. Many people, both patients and urologists, say that progression to muscle invasive disease is oftentimes the worst possible outcome in non-muscle invasive bladder cancer because your prognosis drastically changes, and also the type of treatment that you have available is dramatically different. So in the table at the bottom on the left, if you have non-muscle invasive disease, it's fairly a low stakes sort of surgery, but once you get to muscle invasive disease, you require major extirpative surgery, and that's associated with substantial morbidity, mortality. And at the end of the day, patients don't want to lose their bladder, or they're maybe due to comorbidities are unfit to lose their bladders. And so this has really led to a number of clinical trials in this space. At our American Urological meeting last week, there were even new trials that have read out. And so more of these treatments are coming down the pipeline to help patients spare their bladder and to prevent the risk of tumor progression. but this comes at a major cost. So if you look at the latest FDA-approved agents, that's enclosed in the red box there, you can see that these are very expensive treatments. And so this really emphasizes that we need to have accurate risk stratification to figure out who is at highest risk of progression so that we can intensify treatment, consider these patients for our novel agents, whereas who is at low risk of progression so that we can safely de-intensify treatment. The problem is that what we currently have available is not good. So these are our current guideline-endorsed risk calculators, the most recent one being the European Association of Urology, or EAU, risk calculator. But all of these essentially have a number of issues. They don't reflect current practice, and you can see at the bottom row of the table that the performance based on C index is quite low. We've also looked at all the AI studies in this space. So this is a recent systematic review that we published in Nature Digital Medicine. And here we use something called the Appraise AI tool. This is a tool that we've developed to quantitatively evaluate the methodological and reporting quality of clinical AI studies. And it's been used in a number of other domains. And you can see a number of limitations that are listed here, small cohort sizes. And the bottom line is that majority of the studies in the last 25 years in this space are all low quality. Only one study is considered high quality, and we'll get back to this later. So certainly a lot of work for us to improve on, and so the aim of this study was to apply AI to improve the prediction of non-muscle invasive bladder cancer progression. Hopefully we can identify patients that we can intensify or de-intensify treatment. So this was an international retrospective cohort study together in partnership with the Canadian Bladder Cancer Research Network, the International Bladder Cancer Group, and the European Association of Urology Non-Muscle Invasive Bladder Cancer Guidelines Panel. Together, we assembled the largest bladder cancer cohort in the world, over 12,000 patients, and this is over 100 times larger than prior AI studies in this space. We followed best practices in AI reporting. So this is based on, we follow the Stream Euro framework, which is something that we've developed a number of years ago, which is an AI reporting guideline for urology. Our model was trained on over 3,000 patients from academic and community hospitals in Canada, and then we externally validated this model on over 9,000 patients across Canada, the US, and Europe. The AI model itself, which we call Progression BCA, was based on a random survival force, and that's trained on 14 clinical pathological features. And these are routine information that's available around the world. And we use this to predict time to tumor progression to either muscle invasive or metastatic disease. Our baseline comparator is that guideline-endorsed risk calculator, the EAU risk calculator, and then we evaluate it using a number of metrics that are listed here. So this is just a summary of our cohort characteristics. The main thing that I want to highlight is that not every patient receives what we consider as guideline concordant care. And that makes sense. There are many reasons why patients can't receive this due to comorbidities, availability of certain treatments, or just variation in clinical practice. And I think having this representation of patients who receive or do not receive guideline concordant care is very important. And the bottom line is that our AI model outperforms these risk calculators, generally by about 10%. We also broken it down into a number of clinically relevant subgroups. When you break it down by patient-specific, disease-specific, it doesn't really matter. And the important thing that I've shown in the red box there is that regardless of whether a patient received or did not receive guideline concordant care, our AI model performs better than what's currently available. Similarly, these are other ways to look at performance. So calibration, our model is well calibrated for risk thresholds between 0 to 20%, and it has a higher net benefit than the EAU risk calculator, as you can see by the blue curve there. So what about that AI model that I said was high quality from our systematic review? So in their paper, they actually reported a C index of 0.88. But when we externally validated it on our large cohort of patients, you can see that it's performed very, very poorly. So, we have a good model and stuff, but how do we apply this into day-to-day practice, and what are some of the challenges that our AI model can address? So, one of the challenging groups of patients that we deal with in bladder cancer is this intermediate group. And the reason why is because they have variable risks of progression. It's basically this potpourri of patients that don't fit into the low or the high risk category. And so our current guidelines recommends that we count the number of risk factors that are listed on the screen here, and then you can substratify patients into either 0, 1 to 2, or 3 or more risk factors. And the details in the figure doesn't matter, but the key point is that the management for each of these subgroups differs. But when you apply this risk factor approach to our intermediate risk cohort, and this is the largest intermediate risk cohort in the world, you'll see that the 0 and the 1 to 2 risk factor group, the 5-year progression rate is essentially the same, which means that this approach does not work. When you apply our AI model to this exact same cohort of patients, you get very nice substratification into risk tertiles. So if you're in the lower tertile, your 5-year progression risk is 2%, which is similar to that of low-risk patients. And then in the upper tertile, you have a 5-year progression risk of 17%, which is close to high-risk patients. And so you can see how this can better inform risk-adapted management, and potentially it expands the window for which patients can be eligible for clinical trials. We're able to do the same thing for high-risk patients. If you're in the lower group, 10% 5-year progression. If you're in the upper group, 1 in 4 patients will have a risk of progression. I won't go into the details of this, but the bottom line is that our AI model is also thinking the same way as clinicians. Stage and grade, we know clinically, is the most important for predicting progression. That's what the model also found out as being the most important. Our model is also now currently publicly available on Progression PCA. You can access it on your phone, your laptops, and you basically can punch in these clinical pathological parameters, and you get a personalized prognostication curve, as well as time point estimates for progression at 1, 5, and 10 years. And to close off, this is the largest bladder cancer prognostic study of its kind, over 100 times larger than prior AI studies in this space. It outperforms what's currently available. And what I hoped that I'm able to show you today is that it works well for patients who receive or did not receive guideline concordant care. It improves substratification for patients. It enhances risk-adapted management, and it broadens eligibility criteria for clinical trials. And most importantly, because of the collaboration that we've done with international groups and bladder cancer societies around the world, we anticipate that this is going to be recommended in next year's updates for bladder cancer guidelines, and this is going to be a project that's led by the University of Toronto as the first AI model that's recommended in bladder cancer guidelines. Thank you.
Congratulations, Dr. Kwong. That's excellent. Dr. Sarah New is our discussant.
Hi, Jethro. Really great work, great presentation. I always enjoy hearing updates on what you've been doing during your research years. My question for you is, the model that you were talking about, the high quality one that you externally validated, can you comment on why you think it performed so poorly?
Yeah, thanks, Dr. North, for the question. So we were quite puzzled by this as well, and it actually came up during my thesis defense as well. So I do have a slide to kind of answer this question in anticipation for this. So the reason why it's high quality is because we have access to their model and data. So they have good reporting practices, but it also allows us to criticize their work. And the issues, or some of the issues I think, really comes down to how they coded their data and their model. So the way that they coded sex was using 0 as male, 1 as female. But then about a third of patients, they misclassified their patients. So right off the bat, the data is wrong. The second thing is that one of the variables that they use is calculating this sort of other score. And so I included kind of a snapshot of what the original scoring calculation is, where if you're male, you have 0 points. If you're female, you get 3 points. But they did the opposite in their code. So those are probably some of the reasons why their model did not do well.
Okay, thank you. And one more question. Just in general, how does your model compare to more conventional regression models?
Yeah, so that's a really good question. I didn't have time to show this in the talk, but we also did compare our model to a Lasso-Cox regression model that uses the exact same features as our AI model. And essentially what we've shown is that It is better in all domains as well. Discrimination, it's better. Calibration, clinical utility. And one other thing that is also a little bit newer that's recommended in AI reporting guidelines is to check for model stability, to see how volatile the model is to kind of changes in data, or how influenced it is by just the data set that you have. And we show that the Lasso-Cox regression model actually is more volatile compared to our AI model. So when you look at kind of performance across all these different domains, our AI model is better.
Great. Thanks so much. I'm excited to see what happens with it next.
Great, thank you very much. So our next speaker is Dr. Grace Lee. Grace Lee is a PGY1 resident in the Division of Cardiac Surgery at the University of Toronto. She completed her undergraduate degree in the Bachelor of Health Sciences program at Master University and attended medical school at the University of Toronto. She was under the mentorship of incredible surgeon scientists within the Division of Cardiac Surgery, and the rich research environment at the University of Toronto fosters that. She developed her interest in clinical research in tandem with her love for cardiac surgery. Grace's academic interests include epidemiology, biostatistics, and large data set machine learning. She hopes to apply these methodologies to explore clinical questions within her clinical interests of aortic disease, heart failure, and mechanical circulatory support. When she's not in the hospital, Grace loves cycling, running on the waterfront, and attending Toronto's many live music events. The discussant for her title of the talk will be Associations between High Sensitivity Cardiac Troponin 1 and 30-day mortality following off-pump and on-pump coronary artery bypass surgery, a sub-analysis of the Vision Cardiac Surgery Study. And the discussion is Dr. Terry Yao.
Thank you, everyone. This is the... Okay, perfect. Hi, my name is Grace. So good morning to the faculty, judges, guests, and colleagues. I'm a PGY1 cardiac surgery resident, and today on the behalf of the Vision Cardiac Surgery co-investigators, I'm going to be presenting our study titled Associations between High Sensitivity Cardiac Troponin and 30-Day Mortality Following Off-Pump and On-Pump Coronary Artery Bypass Surgery. And this is a secondary analysis of the Vision Cardiac Surgery study. I have no disclosures. So irrespective of whether, what surgical subspecialty everybody here practices in, most of you have probably seen routine cardiac biomarkers measured after a major surgery. Historically, these may have included creatinine kinase, troponin T, myoglobin, but high sensitivity cardiac troponin is now the gold standard for measuring myocardial injury or infarction after major surgery. And we now know, because of the 2017 Vision Cardiac Surgery study, that even very small elevations in high sensitivity cardiac troponin can have significant effects on 30-day mortality and be associated with increased adverse outcomes, as demonstrated by this Vision study. Now, in cardiac surgery, however, the definition of what constitutes excessive high sensitivity troponin is very different, because we're directly manipulating the heart. And so, as a result, we often see much higher levels of cardiac troponin than we would see in non-cardiac surgery. So in 2020, the Vision Cardiac Surgery study was published, and it was a multi-center international prospective cohort study that established the clinically significant levels of troponin that are predictive of adverse events and mortality after cardiac surgery in particular. So now, looking into a specific subset of cardiac surgeries, coronary artery bypass grafting is the gold standard for treating coronary artery disease. However, it's also a very invasive procedure, and it involves manipulating the heart, disrupting physiological blood flow, and putting the heart on pump in some cases. And so while all these can cause a baseline elevation in troponin, extremely high levels of post-op troponin can also be concerning for surgical complications, such as graft failure, poor myocardial protection, or even surgical trauma. There's currently no consensus on the level of clinically significant high sensitivity cardiac troponin that is concerning or should indicate further workup for these surgical complications. Now, CABG itself can also be separated into on-pump versus off-pump CABG. And you can see on the image on the left, this is an example of on-pump CABG. So it's performed with the cardiopulmonary bypass machine. It involves cross-clamping the aorta, instituting cannulations in the great vessels, and arresting the heart with cardioplegia. Now, off-pump CABG is shown on the right, which basically includes none of these, and the idea is to perform a beating heart surgery. And the idea is that it's more physiological, but a lot of studies have actually shown that they have very similar, if not even slightly inferior outcomes to on-pump surgery. So the Vision cardiac surgery study, first of all, didn't establish the thresholds for CABG alone. It only looked at CABG and AV, surgical aortic valve replacement in conjunction. And it also didn't differentiate between on-pump versus off-pump CABG, which could be considered to be very different procedures. And so as a result, our objectives of the study were to determine, one, the high sensitivity cardiac troponin thresholds associated with increased 30-day mortality in patients undergoing isolated CABG, and two, whether these values differed between on-pump versus off-pump CABG. So we conducted a secondary analysis of patients who underwent isolated CABG within the Vision cardiac surgery study cohort. And to describe the Vision protocol very briefly, what they did was measure routine post-op troponins on post-op day 1 using a standardized assay. And importantly, to remember the upper reference limit of the standardized assay, so what's considered above normal, is actually 26 nanograms per liters. And it's important to keep that number in your head for later on. The primary outcome was 30-day all-cause mortality, and the secondary outcome that we used was major vascular complications, and we use the same exclusion criteria as the Vision cardiac surgery study. So there were two phases to the statistical analysis of this. First, a multivariate Cox regression was performed in order to determine whether or not high sensitivity troponin was even associated with all-cause mortality after CABG. And we included off-pump versus on-pump CABG as an interaction term in this, and we adjusted it for Euroscore 2, which is a predictor of surgical risk. Secondly, we used a natural cubic spline regression in order to determine what the lowest high sensitivity cardiac troponin threshold was that would indicate a hazard ratio of more than 1 for all-cause mortality. And that basically indicates an increased risk of harm. We did this for all CABG, which is the big group, and then we did it separating on-pump versus off-pump CABG, so our two comparison groups. And we found our confidence intervals through bootstrapping. So now in terms of results, the original cardiac surgery study, the original Vision cardiac surgery study included about 14,000 patients. Actually, half of these patients underwent CABG alone. And so 6,500 of them underwent isolated CABG and were eligible for analysis. Of these, about 5,300 of them underwent on-pump CABG, and about 1,100 of them underwent off-pump CABG. Table 1 here basically shows the baseline characteristics of the two groups. So of note, you can see that patients who had off-pump CABG had generally, first of all, fewer preoperative MI, so they were less likely to have had an MI previous to surgery. Patients who underwent off-pump CABG also had a generally lower New York Heart Association score, and they also had a lower Euroscore, indicating a slightly lower surgical risk. Whether or not that 0.1 difference is clinically significant is, of course, up to debate. But most interestingly, despite all of this, they also had a slightly lower likelihood of getting complete revascularization. So now table 2 basically looks at the short-term outcomes between the two groups. And so the first thing that you might notice is that the average post-op day 1 peak troponin level after cardiac surgery is 640 nanograms per liters after off-pump surgery, and almost 3,000 in off-pump in on-pump surgery. And if you remember that upper reference limit of 26 nanograms per liters, it means that we routinely accept troponins that far exceed what is regularly seen in cardiac surgery. Secondly, of course, you can also see that the difference, there is a significant difference between the two groups. So CABG performed on pump resulted in a significantly higher troponin leak than CABG performed off pump. And despite all this, you can see that at 30 days, there's actually no difference in mortality, major vascular complications, or the like between any of the two groups. So now looking at 30-day mortality as the outcome specifically. So our Cox regression basically found that high sensitivity cardiac troponin was associated with greater mortality with a hazard ratio of 1.7. The interaction p-value was positive for off-pump versus on-pump surgery, which basically indicates that the strength of the association varied between these two groups. And this was confirmed by our spline analysis. So basically, this is a spline curve. And as you can see, you have high sensitivity cardiac troponin on the x-axis and hazard ratio on the y-axis. There's a red line that denotes hazard ratio of 1, and anything above this red line indicates an increased risk, so an increased risk above 1. So as you can see, this is the spline curve for the entire cohort, and it shows that the troponin threshold at which there's an increased risk of 30-day mortality is about 6,500 nanograms per liters. And if we break this down between off-pump and on-pump CABG, you can see that off-pump CABG resulted in a much lower troponin threshold than on-pump CABG. So, the threshold at which there was an increased risk of 30-day mortality was about 4,700 for off-pump, and then about 6,800 for on-pump surgery. And the results for major vascular complications were very similar. So the results of this study are important in two main ways. So first, they provide an evidence-based definition of clinically significant troponin elevation after CABG. So the current guidelines say that the definition of MI after surgery is 10 to 70 times the upper reference limit. And as you can see in our study, we found that the high sensitivity troponin levels could reach up to 6,500 or 252 times the upper reference limit before there was a significant impact on 30-day mortality. And so, this is important because first, it helps us prognosticate when it's important to intervene and do something or suspect that there's a surgical complication after CABG. But it's also important because it helps us accurately measure outcomes in clinical trials. So, there's been clinical trials that have compared, surgery to no surgery, and because they use a lower definition of what's considered, MI, they've diagnosed many MIs that, may not have been true myocardial infarctions, and as a result, there may be an overdiagnosis of adverse events in the surgery cohort, systemically biasing these trials against surgery. The second important thing that we've established from this study is that we now have procedure-specific definitions of troponin elevation after CABG, and it helps us to understand the physiology of bypass a little bit as well. So as you can see, the troponin threshold associated with on-pump CABG was much higher than the troponin threshold of off-pump CABG, but they had very similar outcomes. And so, this may lead us to believe that the troponin release during cardiopulmonary bypass, during, the cross-clamping, cardioplegia, cannulating the aorta and such, arises from reversible and non-fatal forms of myocardial injury. And so, that's it. Thank you so much for listening. Thank you to Dr. Freems and Dr. Derek Tam for their insight and dedication as supervisors. And thank you to the co-investigators of the Vision Cardiac Surgery study for entrusting us with their data and with their expertise. And thank you to the Department of Surgery for the opportunity to present this.
Dr. Yao?
Grace, congratulations on an excellent presentation of some very important data. As you've pointed out, it is really the use of a single definition of periprocedural myocardial infarction that has made the interpretation and facilitate the very fractious debates over the implications of randomized trials where patients who are undergoing percutaneous coronary interventions versus off-pump coronary bypass with its implicit warm regional ischemia and traditional on-pump coronary bypass with cold global ischemia and the systemic effects of cardiopulmonary bypass that have really complicated the interpretation of many of these comparative studies. So this is a very important topic, and congratulations to you for presenting it very well. I've got two questions which I'm going to ask separately, and one really relates to the study population and to your statistical power. So as you noted, about 1 in every 6 of the patients in the Vision trial who underwent coronary bypass underwent off-pump coronary bypass. And my question is that if you were to have your ideal trial with a much larger population, let's say 6 or 8 or 10,000 off-pump coronary bypass patients, given the shape and the confidence intervals around your cubic splines plots, what do you think would have been the effect on your analyses and the conclusions that you're drawing from this study?
Thank you, Dr. Yao. That's a very good question and something that we actually debated a lot between Dr. Tam and Dr. Freems and I. So first and foremost, the bootstrapping analyses are two separate analyses with their own sort of subgroups. And so it's not like your traditional analysis where you're comparing, you're comparing one cohort and you're finding confidence intervals that may or may not cross between the two, indicating statistical significance. These were two different analyses done. And so to directly answer your question, I think that if we had, a bigger cohort and more importantly, more event rates that allowed us to kind of perform the bootstrapping analysis a bit more easily, we wouldn't have been able to get like much narrower confidence intervals. But as a result of it, especially with the off-pump cabbage group, the event rate was quite low, and also the population or the cohort that we had to work with was low. And so, my impression is that the numerical difference is probably more important than the confidence intervals, whether or not they cross over, because it's kind of derived from a bootstrapping analysis, which is also derived based on like multiple simulations. So.
Good. My second question really relates to implementation. So you have come up with some thresholds at which additional care for this patient may be recommended. So how would you envision that these thresholds might be applied in clinical practice? And as normally we sort of diagnose preoperative myocardial infarction in the context not only of biomarkers like troponin, but also things like hemodynamic instability, ECG changes, new regional wall motion abnormalities. So would a patient with a troponin of 8,000, but who is hemodynamically stable and has none of the other associated clinical or ancillary testing findings warrant a trip to the cath lab every time, or do you ultimately foresee that you're going to have a different threshold for somebody who has, let's say, a new lateral wall motion abnormality, but a trope of only 4,000?
So I would say in answer to that question, I think ultimately using biomarkers to diagnose a clinical outcome does still have its limitations. And so I think at the end of the day, probably it's more important to look at wall motion abnormalities, whether or not there's ECG changes, and whether or not there's hemodynamic instability. Biomarkers are more used as a sort of, I would say like as a heads up, or maybe as a prognostication tool that maybe there's something irregular and something that we need to look into or just keep a close eye on, but not necessarily as the be all and end all. I think what's more relevant in this situation is, I think even small changes to the surgical technique, so for example, an AVR versus a cabbage or another surgery, I think has different levels of troponin that are considered clinically significant. And so I think it's more indicative of the type of surgery you performed, maybe how many incisions you made, how much times you've maneuvered the heart or cut into the heart, than it is of the be all end all of diagnosing MI based on biomarkers alone. I think what is more relevant is if we were to have sort of a clinical trial like Excel that didn't use clinical signs of MI and diagnosed it basically on biomarkers alone, then this would be more important. The other thing is that this might impact, routine measurement of cardiac troponin, because now we actually have sort of a standard to judge it against. Right now, it's not regularly measured between hospitals, and whether or not you collect post-op troponin kind of differs depending on the surgeon and the practice. And so now we have a better sort of indicator of what is routine versus above routine for troponin elevation. And so, it might influence more surgeons to collect it more carefully, and then if it's high, to then look for further signs of clinical damage or ischemia, which maybe they weren't on the lookout for before.
Exactly. So I think a couple of the most important implications of some very important work. Thank you.
Thank you.
Thank you, Dr. Lee, for that excellent talk. We will move on to our last speaker, but I just want to make an announcement. All the e-poster judges should stay in this room until the end of this talk. So our last speaker of the morning is Dr. Amin Malhotra. Armin is a fourth-year neurosurgery resident, currently engaged in PhD studies focused on neurotrauma outcomes and population health at the Institute for Health Policy Management and Evaluation at the University of Toronto. His talk title is Latent Home Time Trajectories for Isolated Moderate to Severe Traumatic Brain Injury Survivors. A data-driven method identifies distinct outcome phenotypes. His supervisor is Dr. Wilson, and the discussant is Dr. Lipsman.
Thanks very much for the opportunity to present. What I'll start first with is just something we see all the time, a case of real-world uncertainty. This is a patient I saw in junior residency. She's a 55-year-old lady crossing the street downtown. She was hit by a streetcar, GCS 3 on assessment, and had quite a worrisome initial TBI scan with a few areas of contusion and acute subdural, and certainly sort of a tight brain look. She was treated with a decompressive craniectomy and had quite a stormy ICU course. I specifically remember day 3 post-injury, a long conversation with the family. We were asked kind of what is her chance of waking up, what is the chance that she will survive, and what is the chance that she'll ever make it home. So I just wanted to frame the context with kind of a real-world case that we see, on a daily basis. Traumatic brain injury is the most prevalent neurological condition with an incidence 3 to 4 times that of stroke worldwide. That equates to roughly 1 adult injured every 3 minutes in Canada. We also know that TBI is associated with variable post-injury trajectories, and studies looking at long-term outcomes are largely lacking. We've done a great job evaluating outcomes up to the 6 to 12-month mark, but really we're recognizing the highly dynamic recovery changes that are still taking place at 12 months post-injury. Traditional methods of outcome assessment have informed a lot of research in the field, but can be largely uninterpretable to patients. What's shown here is the Glasgow Outcome Scale Extended Score, which is an 8-level ordinal outcome measure that goes from dead to good recovery. And so you can imagine that there's a lot of granularity of healthcare transitions that are lost in this sort of measure. Days Alive and at Home is a potentially useful ancillary outcome measure that we published about in neurology last year, demonstrating the construct validity, predictive validity, and overall utility of it to understand healthcare transitions after traumatic brain injury, particularly moderate to severe TBI. So in this study, we wanted to build on that and quantify community reintegration after traumatic brain injury, and to specifically look at patient and injury factors that are associated with outcomes, as well as to build a clinical prediction model that will evaluate time spent at home up to 3 years post-injury, which is potentially a more meaningful outcome to patients and might inform counseling at the bedside. To do this, we applied a linked population-based cohort method with ICS data. I know that was discussed earlier. A major strength is that it captures all admissions across all of Ontario, and we identified patients managed in trauma centers, so that includes 11 centers in Ontario, and particularly over about a decade. We identified adults using a series of codes to capture moderate to severe TBI. We then looked at home time, but specifically we looked at this in discrete 30-day windows. So we took what's a count and we actually made it a longitudinal outcome measure such that every patient had 36 distinct 30-day interval measures over the 3-year period of follow-up that we could really quantify within each window what did a patient's home time look like, ranging from 0 days spent alive and at home up to a full 30 days spent alive and at home. We then applied a data-driven, unsupervised longitudinal outcome method known as latent class analysis to identify distinct outcome trajectory clusters within this longitudinal data. There's specific additions that we made to account for within-group correlation and variance, including introduction of random intercepts. Once we identified these groups, we then wanted to look at attributes. So we specifically looked at sociodemographics, clinical factors, and injury features. Finally, we wanted to predict outcomes. We categorized outcomes as either favorable, resulting in a high amount of time spent at home, or unfavorable, which led to chronic dependence or mortality events within the interval. This was done using several methods, including machine learning methods, such as random forest and XGBoost, as well as conventional statistical methods like lasso-based logistic regression and full sort of logistic regression modeling. Moving through the results. So we identified 3,004 patients that were eligible for latent class analysis. We sort of expected a male predominance. Injury features were otherwise kind of consistent to larger cohort studies. Importantly, we identified 5 distinct outcome trajectories that are shown here. Also importantly, in the 90 days before injury, there were no differences in home time across the cohorts, which is sort of an important negative finding. These are the trajectories. So there was an early recovery group where there was kind of quick recovery home that was completed within that cohort by about 10 months post-injury, but in the first observation window, 50% of the cohort was home. A slightly different slope, but sort of a similar endpoint at 10 months, where a lot of patients remained in hospital, but actually transitioned home within the 10 months. There was a late recovery group as well. So this group represented 3% of the cohort, but is still a meaningful population that actually took nearly 18 months to sort of to reach home, and sort of between the first and second year, we're really still making meaningful transitions between inpatient care settings to home. There was a delayed deterioration group, also a meaningful small 3% of the cohort, but that initially made it home and then actually chronically declined. And then finally, about a quarter of the cohort was in this poor recovery group where they actually never meaningfully made it to be alive and at home, and actually stayed either dependent on institutional resources or passed away in the follow-up interval. This is a heat map of different intracranial injury characteristics. You can see sort of different hemorrhage components, and the different colors represent sort of the frequency observed across classes. Just because of time, I'll sort of point out a few highlights. Large subdural hematomas and intraparenchymal hematomas were correlated with patients being in the poor recovery group. Diffuse axonal injury was actually most common in the intermediate and late recovery cohorts. And overall, patients in the poor recovery group, in terms of other attributes, were older, more frail, more baseline health resource utilization, and more likely to experience fall-related injuries. One thing to point out as well is that epidural hematomas had the reverse trend. It's sort of widely known that this is a more prognostically favorable finding, and we actually saw a higher frequency in the early recovery group. Some of these findings demonstrate some face validity of these clusters. We then looked at predicting outcome. Just for time's sake, we sort of split into training and testing cohorts, which were held mutually exclusive. Discrimination was evaluated with AUC, and actually there was comparable performance across different modeling strategies. And so what we selected was really the most parsimonious, the simplest model with the least number of features. That was actually the Lasso simplified regression model, and had quite appropriate calibration across the range of predicted probabilities, and demonstrated a AUC of 0.81 on the held out testing cohort. The actual days alive and at home calculator is a tool that's sort of widely available. And so to kind of show in our example here, this is accessible to anyone that can kind of use that QR code. Our 55-year-old lady with decompressive craniectomy, a long ICU course, and several months in rehab, eventually transitioned home with home supports at 9 months post-injury. This sort of using thresholds with our predicted probabilities also correlated to sort of a more favorable prediction with her injury pattern. Of course, I totally recognize the challenges with taking a population-based prediction model and applying it to individual patients. And so really what this prediction model hopefully does is it brings a patient-centered outcome focus of home time and introduces it with different injury and patient factors to sort of build heuristics amongst decision makers, and also to inform conversations with patients and families. Ultimately, we showed a few important things. Despite high upfront institutional resource requirements, approximately 70% of moderate to severe TBI patients actually reintegrate to the community by 3 years. This really highlights that we need to really push our outcome observation window well beyond the 1-year time point that is often used in moderate to severe TBI studies. And prediction of home time was feasible and may potentially be useful for trial risk stratification as we move forward to sort of identify different risk groups within this highly heterogeneous cohort. So really appreciative to PhD supervisors Avery Nathans and Jeff Wilson, as well as committee members, Dr. Kulkarni, Dr. Witu, and Dr. Thorpe, as well as all other co-authors on this work. Happy to take any questions. Thanks very much.
Thanks very much, Armand. Outstanding work. Congrats to you and to your supervisors. So as anybody that does work in TBI knows, there's a kind of nihilism that permeates the field. You know, when somebody comes in, there's not a lot we can offer other than upfront surgery and sort of optimizing critical care. And also, for those that do work in this area, they can immediately recognize the impact of the work that you've done, which is, you know, for the first time, really stratify and identify these trajectories. And the major impact comes in speaking to patients and their families. So huge congratulations on that and the impact that that's going to immediately have. My question to you is simple, well, not so simple, but how do you cross sort of trajectories? What can we now do when we identify somebody to help them move from one trajectory to another trajectory? That's the first question. And the second, we heard earlier about the impact of primary care physicians and access there. Any links that we can make between the two kind of thoughts there, and does that have an impact?
Yeah, great questions, Dr. Lipsman. Thanks very much. I think to your first point about crossing trajectories, one of the challenges is that when we see patients in the real world, you know, this has the benefit of having the data for an entire observation window. So there's always probability, and whether something's stochastic versus deterministic at the moment that you're seeing someone is still something that's difficult to answer from this exact analysis. I think in terms of crossing trajectories, I didn't have a chance to kind of go through all of the baseline characteristics. Certainly some sociodemographic characteristics were very important between groups. They weren't included in the prediction model because we didn't want to introduce things like patient socioeconomic status from income quintiles and Ontario marginalization scores, such as whether they were immigrant or racialized populations or had material deprivation. But some of these sociodemographic factors certainly differed between groups in a direction that was correlated to sort of longer recovery times and potentially membership in the poor recovery group. So there may be modifiable risk factors, and like Elliot presented, we haven't looked at the primary care association, but I certainly think next steps from this work are to basically do exactly what you said, which is try to identify how we can distinguish trajectories and potentially modify this.
Question?
Yeah, I'm glad you broke it down into road traffic injuries and falls. Andrew Howard from Orthopedics. You know, we live in a city where 55-year-olds are struck by motor vehicles, transit vehicles crossing the street. And when we look at the data regarding kids, occupant injuries are going way, way down. Vulnerable road user injuries are coming way, way up. In your data on the, you know, sort of overall, are you seeing that as well? Are you subdividing them? Are there a lot more pedestrians coming your way, like there are coming our way, and cyclists as we take out the bike lanes? You know, like, is this actually showing up there as well? Or are these motor vehicle occupants still?
Yes, great question. So the breakdown here was 50% of the cohort was fall related, and 1/3 was motor vehicle related, actually. So it was, and then the remainder was sort of a mixture of other mechanisms, including assault-related injuries and you know, cyclist kind of injuries. Hope that helps.
Thank you very much. I'd like to congratulate all of the speakers. That was an excellent session and really high-level research.
Thank you, Heather, for chairing the session. A quick round of applause for all of the speakers. So we're actually pretty on time, maybe about 5 minutes over. So I would welcome all of you to go upstairs, grab a quick coffee, go upstairs. We have the e-poster session for the next hour, and then we'll reconvene here at 10:45.